healthcare, both from I'd like to do with you today is tell you a bit from my own domain, so digital mental healthcare, both from adults and for young people before COVID, and then actually what happened after COVID. And then I hope to discuss with you whether the implementations issues that are at stake before COVID will stay the same as after COVID. You see here a black swan, and actually the black swan metaphor is based on the black swan, because we had never seen a black swan, so until we see it, it doesn't exist. But the black swan metaphor actually stands for that something completely happens unexpectedly, like COVID, with enormous consequences, which we are all aware of. Now, we have written very clearly, a group of Dutch researchers in collaboration also with Gerrit Andersen from Sweden, not a manifesto, but a brief paper about what we expected COVID-19 to be like, the black swan for mental health and a turning point for e-health, because I don't know how it happens in your countries, but when COVID came around us, we were 20 years on the road with creating evidence-based and implementation knowledge about digital mental health. And still, just before COVID, we were struggling with implementation. So we thought that we would have digitalized, for many good reasons, important components of our mental health care service delivery to a high degree. And actually before COVID, it was in the Netherlands around 15%, despite all the evidence we had already obtained, despite good technological infrastructure, despite mental health policies on the national and regional level at play. So we were struggling. And then COVID came, and within 3 weeks time, around 90% of the complete mental health care service delivery systems were online. And I will go on a bit on that in depth later on this talk. But really, we think, and I still think, that COVID will change the mental health care landscape forever. Maybe not in the way we experience now during COVID, but after COVID. Another thing, and this is just an example, I take you on a kind of road trip, but what I understand also from you is that this collaboration and data sharing and potentially intervention sharing, that is really something of these moments in times also before COVID. So you see on a European scale many initiatives both in somatic and mental health care to see how can we share data together with taking into account privacy rules, of course, which might be a bit of a bottleneck, but how can we share data and then by sharing apply very sophisticated statistical methods like machine learning and AI to speed up the knowledge circle in a way which is favorable for all of us. And here you see a paper we just published before COVID, where the potential of an European health research and innovation cloud has been explored and set the agenda for future initiatives. Now, we have different channels of delivering mental health care services, ranging from prevention to treatment to chronic support in their daily functioning. And depending on where you are in the stepped care model, a certain channel is more favored or more cost effectively. So here you see 4 formats. The first one is self-guided. That means that a person, a youngster or an adult, follows a treatment, a protocolized treatment or intervention, as we say, but without the interference of a health professional. So it's mostly applied in the prevention field or there where there are mild to moderate problems. And sometimes it's a first step for people who find it difficult to find their way to mental health service delivery, maybe because of fear, of stigma or otherwise. Then we have guided formats of delivery. They are also asynchronic in time. There are two forms of guided asynchronic support. That means youngsters or adults follow a treatment through the internet on a distance, but they can be guided by a health professional or by a therapist, depending on the nature of the treatment provided. So it's also a protocolized treatment over the internet with psychoeducation, often based on cognitive behavioral uh, therapy. It's supported by video, text, all kind of technological innovations. But the crux is that they are guided by coaches if it are brief interventions up to 4 to 6 sessions, or by a licensed therapist when it's an intensive treatment. Then there is another more other form which actually blend, and before COVID that was mostly face-to-face and computer-supported treatment or by the smartphone. And that means you have blended formats in which you have one protocolized treatment protocol, but it is given partly online and partly face-to-face. And what we see in the youngster field, so up to 18 years of age, is that it's not so much an alternative for existing treatment or replacing existing treatment, but it adds on digital components. So that's what we call add-on to treatment as usual. Now, video conferencing is actually an example of not asynchronic in time. So there is a delay in interaction between the person or the youngster that follow a treatment and the reaction of the therapist, and that's video conferencing. So that is distinguishable by that it's synchronic in time, like we are talking now, and actually there is a visual connection between the therapist or coach and the youngster, um, her or himself. Here you see an example. I don't know, you talked about a number of interventions you have included in your database. So I guess there will be digital interventions included as well. One of the latest developments, as you can see here, is that you not only have a patient portal or where you can monitor your progress, make your homework, do all kinds of other things. You can communicate with your therapist. You have a therapist portal which you can see at the right side, so therapists can follow the progress of their patients and give them feedback. And increasingly, this type of interventions are being supplemented with applications by the smartphone. Here you see an example of mood buster, which means that by the smartphone, people can do other things than they can do at the computer in a more easy way. For example, when we want to get insights in the dynamic of a depression among youth, for example, with the smartphone, we can ask them a couple of times a day in a very easy way how they feel, how they have slept. So it's an additional information on what we gather through the computer. I have shown here, this is actually a very generic summary of the current state of the art in terms of effectiveness after 20 years of evidence-based interventions for adults and young people. They differ, so for example, but they also have similarities. And if you are interested in systematic reviews and meta-analysis, I have specifically spelled out them for the youth. So that is amongst others the work by Ebert, but also by a Finnish researcher, Fami Jaki. To be sure, there is much more research undertaken among adults to assess the clinical and cost effectiveness of for common mental disorders than among young people. And there are a number of reasons for that, and I will mention you a couple ones. So, for example, it's much more difficult to recruit young people to partake in research. They like sometimes to work with the intervention, but not to work to partake in research. Often, if they are under 18 years, you need parental consent. So not only your own informal consent, but also parental consent. And often young people don't want their parents to know that they have mental health problems. It's also can be possible that the knowledge we have about intervention development is still much more focused on adults than on young people. So that is a huge difference. So the evidence based for this type of interventions is less robust because we have not so many studies compared to adult ones. But there is a kind of common ground. And that means that when we look at specifically internet guided and internet unguided interventions, these are the most studied. And when we compare both with non-intervening, for example, from depression, we know that guided interventions lead to a better clinical impact than unguided ones. So for internet guided, comparing to nothing, they have moderate to large effects, and for internet unguided, small effects. But you can imagine if you can reach out with unguided internet-based interventions to a large audience, the public health gain is enormous. Despite the small clinical effect size. And when we compared internet guided to face-to-face treatment, we see that the impact or the clinical effectiveness is almost similar to face-to-face treatment, but not for internet unguided interventions. But over the years, and I heard you talking about different kind of sub-target groups, the picture get a bit more, how you say, clearer that for certain subgroups, unguided internet interventions can be also as good as face-to-face, but that is a progress development. Now here at the left, you see all kind of new developments, because in a way, internet and asynchronous treatment is a bit old school almost already. But for young people, I think it's very good. And you also can see from this graph that the number of studies are still limited, and we also do not know as much about their clinical and cost effectiveness as the other two. But I think what is a very interesting development specifically for youth is a kind of new way with a lower accessibility rate, is the use of social networks. So the existing social networks which are out there to provide, for example, preventative interventions for common mental disorders to youth. And that also hold to the MOST approach, which is a multi-channel approach developed by Dr. Jimenez in Australia, who works, who is a specialist in youth mental health delivery by digital means. And he actually combines different channels. So not only social networks, but also peer-to-peer support, also video conferencing. So that's a whole new concept. And although we do not know a lot yet about the effectiveness, we do know, or some studies show, that the acceptability of this type of new ways of delivery is also very acceptable among youth. Now, what we see, and I think there we share common grounds, and I take the Netherlands as an example. So we were in the domain of e-mental health or digital mental health care straight from the start. We started to develop, we have proven effectiveness also for digital interventions for youth, but the uptake to bring these type of interventions to routine practice has been proven incredibly difficult, while even a number of stakeholders were very much engaged, like our Ministry of Health and also what we call role models within mental health service organization who really saw the potential of, for example, prevention or psychoeducation through digital means. But the uptake or the embeddedness of this type of interventions in routine care proved very, very difficult. And that holds among all countries globally. So whether you are a front runner in digital mental health, like Sweden is, for example, or the Netherlands, or when you have almost little experience, this embeddedness in routine care is difficult. And a number of constraints have been identified. And I come back on those later. But this whole implementation field has urged us to have a closer look what actually are we doing with implementation, because you can have a good digital infrastructure, you can have it be reimbursed, but if there is not a win-win for both the health service providers, the health professionals, and the people who have to make use of it, then it won't work. What I have just shown you, and I will skip this intervention, but when you look at the more complex psychiatric disorders among youth, like for example, schizophrenia or severe anxiety disorders, the level of effectiveness and number of studies is even smaller. So a lot of work needs to be done there as well, but it is entering the field. And as I said, most of the time as an add-on to existing treatment as usual. Now, what we actually, and this is again a summary of where we are standing also in the youth domain, that we need to have much more randomized control trials. That's one, so to increase the evidence base so that we can hopefully do more meta-analysis and individual patient data meta-analysis. But of course, we also want to improve the quality of care in terms of clinical effectiveness, but also in terms of creating more accessibility, of creating alternative treatment options. And that's actually, that are the challenging we are currently facing. So we want to do in a way better also than face-to-face treatment. And of course, we want to think about how can we improve implementation. Now here, before I go to what happened during COVID, within actually the context of a large EU project, we also conducted a survey among the countries you see represented on the screen here. And we saw actually a large variation in the level of development of mental health policies and implementation development in the domain of digital mental health care, both for youth and for adults. So while we saw there is variety, with the Netherlands, Sweden, and the UK being the front runners at that moment in time. I'm talking now about 2017, but there are a number of countries who are running fast. That is specifically Germany and Denmark at the moment. So I hope the other countries like Norway and Finland also will start running with us, because I really think if we do it together, that can lead to better results. So this was the hotly debated question. So while working with digital mental health care is, so to say, sexy, before COVID, all the attention was focused on how can we improve implementation in routine care by science. So actually we don't need only evidence-based interventions from a clinical perspective, but we also need to have evidence-informed implementation strategies. And that was felt by many stakeholders on different levels. Now, that was actually a couple of years the start that with my team, we started to focus specifically on implementation. And we conducted a systematic review. Christian Vis is my PhD student, and he actually started to identify the barriers and facilitators that are identified in studies which look specifically at implementation. And those barriers and facilitators, they can be found at the meso, macro, and micro level. And specifically for digital mental health, we found some which are, I think, hold true for non-digital mental health care as well, but specifically from a technical perspective, the technologies you use need to be reliable and stable and acceptable. And of course, interventions need to be evidence-based. But what we also found, and that's also when we delve more into routine care, is that the new technologies also need to be accepted by the health professionals who actually have to do the work. So often we found that on a managerial level, there was loads of enthusiasm for mental health, digital mental health care, but that enthusiasm was not always there at the health professional level, because health professionals didn't always see the win-win. So they thought, well, if it's a new technology, I prefer to see my patients face to face. It is not doing better yet than face to face treatment. So what is for me the need? And another obstacle was as well that I think, and that holds at least for the Netherlands, that we have the mantra surrounding digital mental health care in a number of countries has also been really driven by a cost effectiveness perspective. So the idea that if you apply these type of technology, the costs can go down for mental health care service delivery. And that has been, instead of say, okay, we want to improve the quality of care and access of care, I think that has been a real bottleneck. What is, however, good is that over the last few years, in addition to all those randomized controlled trials, we have conducted also more process evaluation type of studies have been published. There have been established a couple of journals as well, like implementation science. And so that all are indicators of how important implementation is, but also how you learn about implementation. And many more process evaluation studies have been published by now. And now during COVID, something special happens, and I think that happens in your countries as well. And although I think video conferencing is more being more applied in the Nordic countries because of the huge geographical distance, I remember one of our Norwegian partners in an implementation study. It just pops up now to my mind, but it shows on how, coming from a very, I think, one of the most densely populated countries in the world, the Netherlands, talking to a psychologist in Tromsø, who said that they had already loads of experience with video conferencing, not only for professional consultation, but also from providing actually support or help because of the large geographical distance. And I said, well, can you give me an example? What one of the latest contexts come to your mind? And then he said that they provided care on a distance when someone was attacked by a polar bear. So for me, that was completely, I say, almost, science fiction in that way. But there are so differences between the application of video conferencing between countries. But during COVID, what we have not been able in the last 20 years to increase our digital interventions with more than 20% in the Netherlands. And then COVID came, and within 3 weeks, 80 to 19% of all the mental health care services were not delivered asynchronously in time, but by video conferencing. So, and also on a large scale, it was not only that the service organization said we had this on offer, but it were actually the therapists and the health professionals who thought, I need to be there for my patients, so this is the only way I can reach out. And I think that is one important indicator why the change of using digital services went so quick. And in addition to that, there was a huge need of being trained, because the majority of those health professionals, the technical infrastructure was there, but they had never worked with video conferencing. But we trained by making use of Zoom. Literally in 4 months, thousands and thousands of health professionals in the basics of how to provide treatment online. Now, unfortunately, and this is, I don't have the evidence base for video conferencing for youth. While I know it has been applied a lot during COVID, but here you can see 3 systematic reviews for depression, anxiety, and health in general. The evidence we have for the effectiveness of video conferencing protocolized treatment is still limited. So it's not saying that it's not effective. We simply don't know that because it has not been studied so much. You can see there's not even a meta-analysis yet available. That means we cannot pool data based on a number of sufficient randomized controlled trials. The study of Banbury is an interesting one because they looked at group-delivered therapy through video conferencing. Now, if we look at those studies, and the majority were based on cognitive behavioral therapy and psychoeducation or providing support in daily living, the results are rather promising. So they are acceptable to both patients and health professionals, and so far no negative side effects have been reported. But again, the number of studies are very limited. Now, more and more research, of course, need to be done, specifically in video conferencing. We do not know anything yet about the long-term effects. And when we look, although it is acceptable by patients and professionals, we also see that for some groups it might be a very good alternative, and for other groups not so much. So that we need to delve into that in a more deeper way. Now, I actually want to end my presentation with some notes, and then maybe we have some time for discussion. Because during COVID, and I think we hear that recently also in the Netherlands, that the impact of COVID and the lockdown, specifically on the mental health of children and adolescents, and specifically the vulnerable children, for example, those that live in not favorable family situations, or those that had already psychological or psychiatric complaints, they suffer a lot from the COVID epidemic. So there is a need for recognize that, not only, for example, among adults, or not only among frontline workers and first responders, as we do in the Netherlands in terms of aftercare or coping skills. This is a really nice paper which indicates that given now that COVID is even longer under us, that we really have to look at the specific needs of those vulnerable kids and maybe learn some new coping mechanisms, but also that we have to develop new policies within the context of COVID and beyond. And I think all the efforts of ITLA could fit in that purpose as well. Before COVID came, we really started to explore the blended potential, so the combination of face-to-face and digital components, because we really think from a preventative point of view, unguided and guided in an asynchronic manner could provide lots of benefits. But we really think, given the health service delivery, that the future is in blended care, because we see our patients in youth services or at the GP or in the specialized mental health care clinics. And then in that way we can combine the best of both worlds that we were already aware of before COVID came. And here you see a number of studies which we have conducted, and of which the results are very promising, both in terms of acceptability, but also in terms of clinical effectiveness. But I really, and I skip this, I really think that due to COVID, this blending of channels won't be only the face-to-face and the digital, but for example, also the digital and video conferencing, or face-to-face and telephone, face-to-face and wearables. So the future of digital mental health will be in blended, the best channels available. For those of you who are interested in implementation from a scientific manner, we are currently ending the Implement All EU project, and the aim of that project was really to develop evidence-based, informed, tailored implementation strategies. And we actually have conducted a step wedge design in 8 EU countries to assess the implementation success of these strategies. So not the clinical outcome, but the implementation strategy outcome. And we have developed an ITFIT toolkit with which you can tailor your implementation strategy, which will become available open source in start of next year. And on top of the toolkit, all kind of other supportive implementation instruments are coming available from that project. So if you are interested, we can provide you with more information. Petra will also start to work with it. And what I really think for the future is implementation, but I also think, and that makes the circle round with your initiative of this Nordic collaboration, I really think that sharing of data, sharing of information, sharing of implementation knowledge will really bring our world one step further. And working digitally or providing digitally mental health care is not an end in itself, but is a mean to get there. And I really think that COVID-19 will act as the black swan and the turning point for mental health service delivery, because we have now experienced in a half year the potential of working digitally, and as well the importance of sharing knowledge, that I really think that we need to keep the experience we have now with us, and really to think or continue to think about the importance of sharing and access to data, although we are also confined, of course, by the general data protection rules and the FAIR principles. But I really think the future will be in open source and support each other. Thank you.